So as an act towards reconciliation and to honour the authentic history of the original people of the territories we gather on, I would first like to acknowledge that at UBC Okanagan, I'm on the end of the traditional, ancestral and unceded territory of the Salix Okanagan Nation. So it gives me great pleasure to introduce our speaker today. Our speaker is Dr. Azadeh Yadolahi, who is a senior scientist at the University Health Network's Kite Institute, and is an associate professor at the University of Toronto. For those of you who don't know the Kite Institute, I think the Kite has got a fantastic name. It's an acronym for Knowledge, Innovation, Talent Everywhere, which I think is the best name for a research centre I've seen. And this is a world-leading centre for the complex rehabilitation of people living with the effects of disability, illness and ageing. So I think that fits really nicely for a lot of people across our two schools who are interested in a number of sort of areas associated with those things. So I first became aware of Azadeh's work about 7 to 8 years ago when she published some really novel papers about how overnight fluid shifts from the legs. This fluid moves towards the head and the neck and contributes to the severity of obstructive sleep apnea. And she also did some work on how exercise, which is more my interest, may have some real benefits for treating individuals with this very prevalent condition. Since then, Dr. Yadolahi has truly become a leader in this field, and she's published an impressive volume of work in some of the top respiratory and clinical journals in the world, and is a highly sought after speaker in universities and conferences. So it's great to have her come and speak to us today. It was also around this time that Azadeh's name came up in a number of conversations at respiratory conferences and meetings, not only for her interesting work that she was doing, but also because she was taking a different approach to her work. She has a training in biomedical engineering, and I was hearing that she was building a lot of her own specialized equipment and taking a novel approach to answer some of these really important clinical questions, but approaching it from a different way from those of us who are trained more in physiology or medicine. So this work has now led to Azadeh holding a unique position as a Canada Research Chair in Cardiorespiratory Engineering in the Institute of Biomedical Engineering at U of T. It should also be acknowledged that in addition to her research, Dr. Yadolahi is a strong advocate of inclusion, diversity, equity and accessibility, and is the current chair of the University Health Network's Research Idea Committee, which is an acronym of those 4 important elements. So thank you, Azadeh, for agreeing to speak to our 2 schools. I apologize for the late hour it is. It's 7 p.m. there in Toronto, and it's a real shame that we couldn't have had you here in person, but it's a privilege for us to hear you talk, and thank you very much for doing this.
Thank you very much, Neil, for the invitation. And I'm so humbled for the introduction and so happy and so humbled that you have me here for this talk. And so looking forward to hearing back from you and from the other audience in the room of what they think about the research. And please feel free to stop me at any time or wait for at the end, whichever that works better for you. So as Neil mentioned, what I'm going to talk about is about the concepts of the rostral fluid shift as a unifying mechanism between asthma and sleep apnea and how exercise could modify this mechanism. You all know far better than I do that aging population is a challenge and at the same time an opportunity. And cardiorespiratory disorders are among the most common disorders in the aging population. And also the COPD and heart failure are among those that are having the high risk of readmission in the population. And when it happens to look at the aging population, what is even more striking is that they have multiple chronic disorders at the same time. So looking at the cardiorespiratory disorder in just one problem at a time doesn't look at the situation of the aging population properly. And that's what brought up to my research of looking at common disorders. So as you know far better than I do about the heart failure, it's affecting about 1 million Canadians, and it's a #1 cause of hospital readmission. This is how a normal airway looks like in a healthy individual, and this is how it looks like in someone with COPD, which is the #1 cause of hospitalization and the 3rd cause of death globally. The other common disorder is asthma, which is due to reversible airway narrowing. And unfortunately, it is not well controlled in 90% of the people who are experiencing asthma. And finally, sleep apnea occurs due to the narrowing of the pharyngeal airway during sleep, and then those frequent collapses of the airway during sleep. And it's common in about 10% of the Canadian general population. But what is quite important is that there's a high overlap between these disorders, so sleep apnea, heart failure, asthma, and COPD. And what is even more striking is that in all these conditions, a lot of the risk factors happening during the sleep. So 91% of heart attacks that lead to are happening during sleep. Also in people with COPD or asthma, more than 50% of the death occurs during sleep. And that brought us to the question that how we can have a transdisciplinary patient-oriented research program to have a holistic approach for implementing an age-friendly healthcare system with the goal that it's reduces the risk of exacerbation and hospitalization in people with cardiorespiratory condition. And that will bring us on the concept of the fluid shift that we are working and what these cartoons are showing. So this one is the lifestyle of many of us, that we're spending a lot of time sitting. And what happens is that due to the gravity, part of fluid in the body is basically accumulating in the legs and remain in the leg. And that just because the balance of the pressure between the veins or capillaries and extravascular and intracellular space is driven by the pressure. So sitting a lot of time will lead to a lot of fluid accumulation in the interstitial space in the legs, very much similar to what happens after a long flight. And then when we lie down to sleep, and now there is no gravity, what happens is that part of that fluid that has been accumulated in the legs during the day is now moving out of the legs to the upper body. And part of that gets into the tissue around the neck and could narrow the pharyngeal airway and increase the risk of a sleep apnea. And part of that can get to the small airway wall in the lungs and potentially narrow the airways in those with asthma. And that's the main hypothesis that we're looking at, how the fluid is shifting, how much of that contributes to the pathophysiology of these disorders, and whether we can have better treatments. So one of the things that I did during my postdoc in Dr. Bradley's lab was to develop a system to non-invasively and continuously measure the fluid in different body segments. And that would be in the neck, in the thorax, and in the leg. And it works based on a very simple idea that fluid is a good conductance of electricity. So if you measure the electrical impedance of a tissue, if there is more fluid in the tissue, which is a good conductance of electricity, there is less resistance. And if the fluid is reduces, then there would be more resistance in that segment. So by measuring the bioelectrical impedance and then knowing the shape of that, like the length and circumference, we can estimate fluid. So what we have done was to look at this role of fluid shift in different experiments. In one experiment, we had healthy men and women to lie down for 90 minutes. And then we measured fluid in the legs, abdomen, thorax, and neck in all the participants. Here, the red shows the female data and blue shows data from men. The horizontal axis is time in minute, and the vertical axis is the change in fluid from the time zero that they lie down. The first one is the change in the leg fluid volume. And as you can see, the fluid is decreasing exponentially in all men and women. This one at the bottom left is the change in thoracic fluid volume, that While lying down, fluid is increasing in both thorax in both men and women, and it seems that fluid is increasing more in men compared to the women. And similarly, when we look at the neck fluid volume, it increases in both of them over time, but the increase is more in the men. And that could be one of the reasons that men are having more sleep apnea compared to the women. And these results were also associated with larger increase in neck circumference in men than women. We also tried to see what happens if we look at the effects of fluid overloading. And that was on the sleep apnea severity. And the hypothesis was that fluid overloading will increase the risk of sleep apnea in older men. So what we have done was the people without severe sleep apnea were recruited, they were randomized into a control or intervention. And during the intervention, both of them were daytime sleep studies. And during intervention, what we did was to inject about 2 liters of saline through intravenous injection when they were in the stage 2 of sleep. And within 2 weeks, they went to the other arm of the study, and the control arm was just sleeping. And we looked at the sleep fluid volume, but also the sleep apnea severity. And we look at the data in those who were younger than 40 and older than 40, because 40 is the age that the sleep apnea severity increases. And what we found here, the vertical axis shows the sleep apnea severity as assessed by apnea-hypopnea index, which is the number of respiratory events per hour of sleep. And less than 15 or 20 is considered to have non-severe sleep apnea. So what we found was that in the younger group, there was no change in sleep apnea severity from control to the intervention. So even with 2 liters of saline, nothing happened. While in the older group, there was a significant 3-fold increase in the sleep apnea severity. And this was actually associated with a significant increase in blood pressure from before to after sleep. So first of all, it shows that yes, fluid accumulation or fluid overloading increases the risk of sleep apnea. And that has a very important clinical relevance, especially for what happens during surgery and why people are developing sleep apnea after surgery. But we are also interested to see why some of our population did develop sleep apnea and some of them don't. And we continued data rolling and we grouped the subjects not basically based on the response to fluid shift or fluid overloading into those that developed sleep apnea. Those are the AHI negative group, compared to those that developed sleep apnea with saline infusion. And we looked at so we have a very unique sort of a study or experiment that we are inducing sleep apnea or worsening sleep apnea in these people. Did you hear me or did you lose me? Okay. And what we did was to look at the heart rate variability before and after saline infusion as a measure of the changes in the parasympathetic activity and vagal tone. And we looked at the low frequency and high frequency components of the heart rate variability. And what we found was that in the group that developed or worsened their sleep apnea with fluid overloading is the group that, in fact, fluid overloading reduced vagal tone activity. And that is one of the mechanisms through which they developed sleep apnea. And also they had an increase in blood pressure. We also looked at the other way around, that what happens if we take fluid out of the body? And we did that with ultrafiltration in people with renal failure. And that was 2 arms of the study, 2 sleep studies. At the baseline was just a regular sleep study, and then they did ultrafiltration in a follow-up, and we did another study after ultrafiltration. And in that procedure, we took about 2 liters of fluid out. And that's the work of my colleague, Dr. Lyons. And what we found was that in this group, taking fluid out was associated with about 36% improvement in sleep apnea. And this was also associated with improvement in the sleep structure. We also try to see whether fluid has any relevance in the general population with a sleep apnea, and then whether there are ways to reduce the effect of fluid shift. And what we have done was, in a group of people with a sleep apnea, so that's the general population, we asked them as the intervention to wear compression stockings below the knee compression stockings for 2 weeks during the day, with the hypothesis that the compression stockings will prevent fluid retention in the legs, will reduce overnight shift of fluid out of the legs and improve sleep apnea. And that's what happens. So in the control group that they didn't have compression stocking, there was no change in the sleep apnea severity from baseline to 2 weeks after. While in the compression stockings group, they had a significant 25% improvement in their sleep apnea severity. We also did something similar in terms of the mechanism of intervention, but walking for 30 minutes during the day, once a day. And the idea was that walking for 30 minutes without any other change is going to activate the calf muscles and reduce fluid retention in the leg. And again, what we found was that, and this is the people that went to the cardiac rehabilitation. In the control group, there was no change in the sleep apnea severity from baseline to 4 weeks. The duration was 4 weeks, while in the exercise group, there was a significant reduction in the sleep apnea severity by about 36% just with 1 week of half an hour walking per day. And then this was also continued when we looked at them 6 months after the treatment. And there's a lot of evidence from the people saying that just walking even to the work and back improves their snoring or sleep quality. And in this group, we also found that their fluid retention in the legs reduced after exercise, and then there was less narrowing of the pharyngeal airway during the sleep with exercise. So what all of this so far showed was that when lying down to sleep, fluid moves out of the legs to the neck and narrows the pharyngeal airway and increases the risk of a sleep apnea. And then reducing fluid retention in the leg improves the sleep apnea. Now, the question is what happens when of the fluid that potentially goes to the thorax in the lungs. So we did different studies in people who are experiencing asthma, and then to see what happens in that population. So this is a daytime study. It's that what we have done was to have healthy population and those with asthma to lie supine for a half an hour. And during the control arm, they're just lying down. During the intervention, what we did was, these are like shock pants that have air bladders in them, that if you inflate them, they're going to add pressure around the legs and shift fluid out of the legs to the upper body. Very much, I mean, that's what basically they use when people are having low blood pressure, to control of the blood pressure. And the amount of the fluid that is moving out of the legs with these shock pants are similar to the amount that happens overnight. And then we did measure the airway resistance with forced oscillation technique from at the beginning and after 30 minutes of the lying down in both study arm, and we also measured fluid. And here what we have is the data. The blue is the data in the healthy population, and the red is in those with asthma. The first graph on the vertical axis is showing the change in the leg fluid volume, and then also the change in the thoracic fluid volume. And just by lying down, what is important to notice here is that with our intervention or lower body positive pressure, there was more fluid coming out of the legs and more fluid getting into the thorax compared to the control arm. And when we looked at the airway resistance, which would be, it has two components of resistance and reactance. And the resistance shows the narrowing of both large and small airways, and reactance with this method is more of a measure of the narrowing in a small airways or lung stiffening. And the more negative means more narrowing. what we found was that there was no change in the healthy population with the extra fluid getting into the thorax. But in those with asthma, both the resistance increased and then the reactance became more negative, suggesting that individuals with asthma had more narrowing in the small airways, potentially because they have a smaller airways to start with. So with similar amount of fluid getting to the walls of the airway, they are at higher risk of developing a narrowing in the airways. And that's actually what we found, was that women were higher risk of a small airway narrowing, and because women also have smaller airways or narrower airways to start with. We also looked at the effects of the treatment or the common treatments for such as bronchodilator, and whether the bronchodilator can prevent the effects of fluid shift. So we did a very similar experiment that the people were just lying down supine, and then we apply lower body positive pressure to shift fluid out of the legs. But this time what we did was that they either received placebo before the experiment or bronchodilator, short-acting bronchodilator. And the hypothesis was that whether there would be the changes in the airway resistance will be different between these two arms. And what we found was that either before or after giving bronchodilators, either with placebo or with bronchodilators, there was a significant increase in the airway resistance and also at the airway reactance, suggesting that the bronchodilators did not prevent the airway narrowing with fluid shift. We looked at what happens if the people with asthma wear compression stockings to reduce fluid retention in the legs during the day and potentially improve their sleep apnea. And what we found in about 11 participants was that with wearing compression below the knee compression stockings for 2 weeks, there was a reduction in the fluid retention in the leg, and then the airway resistance before sleep was reduced. So there was less narrowing in the airway resistance. The overnight changes were similar in the control arm with no compression stocking and after wearing compression stocking. So the compression stocking did not improve overnight narrowing in the airway resistance. And that is potentially because our population with asthma were well controlled and they were not fluid overloaded. So these evidence suggests that fluid in the fluid shift overnight can contribute to the higher risk of airway narrowing in people with asthma. We also looked at the overnight fluid accumulation in the thorax in people with heart failure. And what we found was that in those with central sleep apnea, so heart failure people with central sleep apnea, when we look at the average CO2 pressure overnight, there was a significant reduction in the average CO2 overnight. So with more fluid in the thorax, they had a smaller CO2, and that is potentially the mechanism that makes the airway control unstable, because the control of the breathing is dependent on the CO2, and more fluid in the thorax in people with central sleep apnea could affect the respiratory sensors in their thorax and then the control of breathing that leads to lower CO2 level, more unstable breathing, and more central events. So these two together are sort of showing that now fluid in the thorax narrows the small airways in lung, in the neck, narrows the airways and increases the risk of sleep apnea. But is there a relationship between these two? Are these just two things happening at the same time? Or something, also there is a synergistic effect. And our hypothesis here was also coming to some extent because of the high overlap between asthma and obstructive sleep apnea, was that in patients with asthma, when we go back here, what happens is that when there is narrowing in the pharyngeal airway during sleep, for example, in those with obstructive sleep apnea, in order to resume the breathing, the people are going to make more negative intrathoracic pressure or more suction to be able to get air in. But because lungs and heart are both in the thoracic cavity, that more negative intrathoracic pressure will pull more blood from the extremities to the heart, and that extra blood to the heart is going to also increase the blood volume in the pulmonary airways and pulmonary circulation, and increase the blood pressure in the, or basically blood volume in the small air, in the walls around the small airways, and then lead to the narrowing of the small airways. And that's what we tried to simulate. And the idea was that if we have people with asthma and without asthma, and we simulate obstructive sleep apnea by doing a Mueller maneuver and basically having the people to breathe against closed mouth and nose to increase negative intrathoracic pressure, would that increase the thoracic fluid volume and airway resistance? So the study protocol is a randomized, it's a daytime study, and they lie supine for about half an hour. During the control arm, they're just breathing normally, and during Mueller maneuver, they're performing 25 Mueller maneuvers, each for about 15 seconds. And during the procedure, we are monitoring their pressure, the intrathoracic pressure. So they're instrumented, we monitor their intrathoracic pressure to make sure that they generate minus 40 centimeters of water. And that is similar to what happens during snoring or obstructive events. And then we compare the thoracic fluid volume and airway resistance between the control and Mueller maneuver arms. And again, the blue is healthy participants and the red are people with asthma. And what we found was that in both groups, during the Mueller maneuver, there was a significant increase in thoracic fluid volume and reduction in the leg fluid volume. Actually, reduction in leg fluid volume is not very different between the two arms, but there was a significant increase in the thoracic fluid volume, suggesting that those negative forces increases fluid in the thorax. And only in the people with asthma and not in the healthy groups, the extra fluid in the thorax led to narrowing of the both large and small airways, and also more negative reactance that shows more narrowing of the small airways. So just by simulating the obstructive events through Mueller maneuver, we showed that the people with asthma experience more narrowing in the small airways. And in a subsequent studies, we actually looked at the overnight increases in the thoracic fluid volume and the airway resistance in people with asthma, those with and without sleep apnea. And we found that those with the sleep apnea had larger increase in thoracic fluid volume in association with more narrowing of the small airways, which suggests that fluid accumulation in the thorax could be a mechanism that links asthma and obstructive sleep apnea. And this is a study that just got funded through CRHR for a patient-oriented research. And that's the two main messages that we got that can help us to have a better understanding, basically that having a better understanding of the pathophysiology of fluid accumulation in the thorax and neck can help us to incorporate fluid management as an alternative treatment for people with cardiorespiratory disorders, specifically those that have hard to control asthma or not respond to the common treatments, or for example, don't like CPAP for sleep apnea. And what we did moving that forward is that it's quite good to be able to monitor fluid, but having those electrodes attached to the people is not convenient. And there is a lot of work happening in my group and also in KITE of how we can incorporate sensors into the textile. So instead of gel electrodes, use dry electrodes that can be incorporated into the clothing for recording physiological signals. In this case, for example, the bioelectrical impedance and the fluid. And this is a prototype that my student is working on of recording data with a sock that had fluid monitoring embedded into that. The other type of technologies that we're working on are a lot about the sleep apnea assessment. And you all know far better than I do that at least, actually, the case in Vancouver is better, or at British Columbia is better to some extent than Ontario, that in Ontario, everyone to get diagnosis of a sleep apnea should go to the lab for a full overnight polysomnography, which is not accessible to many people. And that leads to high underdiagnosis of a sleep apnea. Also, at the end of the day, doing an overnight study with 20 sensors, the only thing that comes out is apnea-hypopnea index, which is the average number of events per hour of sleep. And there's a lot of evidence that that number has very poor prediction capacity for the outcome, especially in people with chronic disorders, common disorders. And the adherence to treatment, or the common treatment for sleep apnea, is quite low. So one of the things that we have done was to see what we can do in terms of better diagnosis of the sleep problem. And we developed a small wearable technology we call the patch that can neck. It has a microphone to record the respiratory sounds. And because it is over the suprasternal notch, it can also record heart sound with a very high quality. And it has an accelerometer to monitor posture, but also movement of the trachea or the neck, suprasternal notch. And then we showed that this technology can use disorders, phenotype sleep disorders, and also monitor cardiac function. So some examples of the work that we have done with this device is that if we just use a tracheal sound and then oxygen saturation level in the blood, so we had a population of people that come to the sleep lab for full polysomnography, and they also at the same time did the data recording with the patch, and we showed that in about 70%, there was a high correlation between the apnea-hypopnea index based on the patch and based on full PSG. And you could actually even detect individual events with high accuracy. We showed that we can make it even simpler and just look at the oximetry, and we still by more advanced signal processing method, we have a high accuracy to detect the sleep apnea. We did that just based on the movement, and then with deep neural networks, we had a high accuracy of detecting sleep apnea severity. We did very similar thing by just looking at the chest movement. And one of the interesting chest movement, and I come back to that, is we're interested in developing clothing for monitoring a sleep problem. And chest movement is one of the things that we can it's easier to record with a clothing like a smart shirt. We also showed that we can just look at the tracheal sound signal and just based on the sound itself, detect inspiration from expiration, and then identify these respiratory phases during the sleep with high accuracy. We can even go more in sort of non-traditional methods based on computer vision. So this is our people in the sleep lab. We're doing overnight sleep study, and we're looking at an infrared camera in the room to get pictures of them while sleeping with blanket in different body posture. And just by doing the computer vision, we can detect their posture, we can detect the risk of a sleep apnea, and even by separating the movement of the chest, abdomen, and then the neck or face, we can differentiate between central and obstructive sleep apnea. You all know that there's a lot of interest in recording airflow and looking at the shape of airflow during a sleep as a potential signal to look at not only the severity of a sleep apnea, but the phenotype of a sleep apnea and where can be the site of collapse in the pharyngeal airway. And what This data is showing at the top is the nasal pressure or airflow recorded with the nasal pressure. And then we did also recording with the sound, and this is the sound energy and then the estimated airflow from the sound. And these are all the data recorded during sleep. And what it shows is that during normal breathing, we can very nicely estimate the shape of the airflow and the both inspiration expiration just from the sound that correlates with the actual airflow recorded with nasal pressure. Even when the people are snoring, like this high oscillation in the shape of the airflow, still we're able to remove the effects of the snoring from the sounds and estimate the shape of the airflow, and which is the third graph. When there's hypopnea, which is reduction in the airflow amplitude, our estimated airflow just from the sound also shows the changes in the amplitude of airflow that resonates with the changes in the actual airflow. And when there's apnea or complete stop in the breathing, as you can see here with almost no breathing airflow, the sounds also show a significant reduction in the estimated airflow. So all of these suggest that we can incorporate sound as an easier way to estimate airflow. These are examples during normal breathing, but for example, airflow estimation during exercise is also a big input of interest. And there's a lot of challenges of how to record airflow and how sound can be a surrogate measure to assess airflow and the changes in airflow. We also showed that because when we are recording data with our sensor over the neck, it's because the suprasternal notch is so close to the jugular vein, we also record heart sounds with a very high accuracy. And we developed algorithm that basically we can, from the tracheal sound recording, we are separating heart sounds from tracheal sounds, even when there's a snoring. So here's an example of the ECG recorded data with during the sleep. This is the sound recorded with the snoring, and you can see that the snoring masks the heart sounds, and still we are able to analyze the data, remove the effects of the snoring, and extract those first and second heart sounds. And by looking at the changes in the heart sounds and heart sound intensity from before respiratory events to after respiratory events, like for example, from before apnea to after apnea, what we have shown was that there is a significant change in the heart sound intensity, both for S1 and S2, from before a respiratory event to after termination of respiratory event. And that is also associated with significant increases in heart rate that could contribute to the higher risk of cardiovascular and hypertension in those with sleep apnea. We have tried to do a few more cool studies of, again, based on the sounds, and by looking at sounds as a way of doing acoustic imaging of the airway. And what we have done here is that we assume that the pharyngeal airway is like a music instrument, like a pipe. And just shape of the pipe is going to be affecting the quality of the frequency component of the sound. The same way that if you're blowing in a pipe, if it is longer, then the pitch frequencies are going to be less. And then if the pipe gets narrower, the intensity of the sound increases. And that's exactly what we found, that from the snoring sound analysis, we can have some estimate of the shape of the airway, including narrowing and the length of the airway. We looked into whether we can use ultrasound and then vowel articulation to assess the shape of the airway. And the reason is that the position of the tongue is quite important to define the narrowing in the airway. So if the tongue is going more back, either because it's bigger or it's more collapsible during the sleep, then it's going to narrow the airway more. The other situation, but it's so hard to do anything during the sleep to look at the tongue. But the other situation that changes the position of the tongue is vowel articulation. So when we say something like E compared to R, then the shape of the tongue is changing. So in the vowel like E, the tongue is more forward and upward, so the airways are open, or the pharynx is more open, compared to A, that the tongue moves back, and that narrows the shape of the airway more. And we actually developed a protocol based on ultrasound to look at the size of the airway in 2 dimensions during vowel articulation. And what we showed, and then we looked at the size of the airway and how it is changing in different vowel articulation in those with and without risk of sleep apnea. And what we found was that, first of all, the anterior posterior diameter of the pharyngeal airway is larger in a healthy population compared to those with the risk of a sleep apnea. So we can use ultrasound as a novel method to look at the shape of airway. And when we look at the changes in the diameter from in the 2 vowel, like the C and S as the 2, like E and A as the 2 extreme cases of the tongue position, first of all, the healthy population have more opening at the beginning. So we can compare here at the E, the anterior posterior diameter is larger in the healthy population compared to those with risk of sleep apnea. And then when they say that is going to narrow that, the healthy population have more changes, which means compared to those at risk of sleep apnea. So it says that either because their tongue is smaller or it has better control, they have more flexibility or more movement of their tongue position. And this also correlates very nicely with the imaging studies, that the people with sleep apnea have more less flexibility of the size of the airway. And finally, we talked about the potential alternative treatments for sleep apnea in terms of by controlling fluid retention in the leg. And we talked about the effects of compression stockings, effect of the exercise that both reduce fluid retention in the leg and improve sleep apnea. Another thing that we have done was to see what happens if we use electrical stimulation of the calf muscle to simulate walking. For example, in those who have mobility challenges, or even the people that are sitting for a long period of time. So what we did was that the people were sitting, so these are the people with mild sleep apnea. They were sitting for 2 hours, 2.5 hours, and they either received nothing or electrical stimulation of the calf muscles to simulate walking. Then they lie supine for 60 minutes. And then we measure the fluid in the leg and in the neck when they lie down. And also when they're sitting, we also measure the neck circumference, fluid in the neck, and their snoring at night. And what we found was that here the dark bars are the sham electrical stimulation, and the light bars are those during the active electrical stimulation. And what we found was that when they just go from the sitting to the supine, we have an immediate change in the leg fluid volume, which was larger in the sham electrical stimulation group. So this group had more reduction in their leg fluid volume when they just lie down. And when we looked at the changes in the neck fluid volume and also the neck circumference as a measure of the fluid accumulation in the neck over lying down for 60 minutes, is that in the group that had sham electrical stimulation, so basically just sitting for 2.5 hours, that now can happen to many of us during the day in long meetings, they had more fluid in their neck fluid volume getting into the neck, either immediate change in the posture or just lying supine for 60 minutes. And that is also reflected in the change in neck circumference. So from during that 60-minute lying supine, those with the sham electrical stimulation while sitting had about 1 centimeter increase in neck circumference, while in those that received electrical stimulation, it was about 0.3 centimeter. So even just a very acute intervention reduces the fluid accumulation in the neck, and the people after the active electrical stimulation had less snoring overnight. And all of these are sort of coming together that by controlling fluid retention in the legs, either by exercise or compression stocking or electrical stimulation that can be embedded into like clothing, we could have alternative treatments for sleep apnea and potentially asthma. This is my lab at the Toronto at the Kite, which is a soundproof laboratory to examine breathing, sleep disordered breathing. And it is soundproof because we can then simulate different environment and different noises or different lighting of the environment. Like, for example, the sleep quality in the ICU or someone's room, or if they're just sleeping on the road, and then developing technologies to better assess a sleep problem. And these are the different technologies that we have in the lab to be able to assess both lung function, cardiac function, and exercise. And this is the group that I'm so thankful to all of them for the excellent work that they have done and the contribution to the research. Thank you.
Excellent. Thank you very much, Dr. Yadulahi. That was an excellent talk. So as we normally do, if you have questions and access to your microphone, you can unmute and ask, or if you need to, you can send your questions via the chat to me, Chris McNeil, and then I can ask them on your behalf. While we're waiting, I might jump in and just in one of your last studies there about you sort of said sham electrical stimulation. I'm curious as to, because I use a lot of that in my neuromuscular research. So is it just really low current, or how exactly do you fake the electrical stimulation? Oh.
It was a low current electrical stimulation to the point that it wasn't, I mean, we couldn't see the contraction of the muscle. Okay, so they could feel sort of a subtle stimulation to the surface of the leg, but they didn't actually get muscle contraction. Exactly. Neat.
Thank you, Azadeh, for a lovely talk and for some really, I mean, you've got a whole wealth of data there. It's such a volume of studies that you're actually doing to investigate this actual problem. I've got two just sort of quick and unrelated questions. The first one is, I'm really interested in this link between volume shifts and sort of the changes in the airway diameter associated with asthma, which may obviously, influence the obstructive sleep apnea aspect as well. But have you been looking at the sort of airway hyperactivity that occurs with this as well? Are you seeing differences in how the airways react after they've been exposed to this sort of volume load, which is changing the sort of the airway diameter? Are you seeing a greater response to methacholine, or have you measured sort of airway inflammation within sputum or something like that to see what the inflammatory mediators may look like? Is it causing a worsening of the disease, or could it actually be an initiator of the disease of asthma in some adults?
That's an excellent question. And we have not looked at that yet, but that is something that we just started looking with the group in McMaster, that when we are recruiting the asthma population, first of all, do a more phenotyping of them. So really do the sputum induction and then look at the counts to see what is the phenotype of the asthma they have. Is the response is going to be different or not? And we haven't done the response to methacholine, is if that is going to be different or not, more because of the feasibility, not the feasibility, but in terms of the capacity that we had. We did the bronchodilator from the other side, but we didn't do a methacholine test. We're also interested in looking at where the fluid is going and does it really cause a narrowing of the small airways. So we are working on, and that's part of what was partially funded by CIHR for 1 year, to do imaging, high resolution CT imaging of the people after a duration of treatment for their sleep apnea, and see whether that in those with asthma and sleep apnea, preventing, basically treating sleep apnea to prevent overnight fluid accumulation in the thorax because of that increased negative intrathoracic pressure would have any effect on the airway size.
Thank you. That's great. On just a very quick secondary note, from the exercise side, do you know anything about the timing of exercise before sleep? I mean, and is one bout the way to go, or I mean, is it now? I mean, there's a real movement towards, you know, let's reduce our sedentary time, let's get up and do some exercise here and there throughout the day. Do you know whether, if we're sort of more frequent in the amount of exercise we do, even though we might do the same volume of exercise, do you know whether it's the frequency or what's the timing sort of concept here for reducing fluid shifts at night?
That's an excellent point. And what our research is showing is that if you do the exercise toward the late afternoon, that is better because now you probably have more fluid accumulated that then by exercise you're working on basically removing the fluid from the leg and then getting into the renal system to be secreted. So not right before the bed, but a few hours before bed. And there are also evidence, not from my work, I haven't done any study to look at the timing of the exercise, that whether how that will affect the airway narrowing and or even the sleep apnea. But there are studies on the control of blood pressure during the sleep or changes of the blood pressure during the sleep with the timing of the exercise, that in everyone the blood pressure should reduce during the sleep, but in those with the sleep apnea or the problems like with the hypertension, it doesn't. And then if people are exercising in the late afternoon, they experience more drop in the blood pressure at night.
That's great. That's really interesting finding. Thank you very much.
Okay, Phil, if you'd like to go next, please.
Oh, okay, thanks. Simazio, that was such a fascinating talk and incredibly impressive how you work in, you know, bioengineering, physiology, medicine. It really is terrific and how it should be, I think, in this kind of field. I've just got a few questions, and some of them might be just reflecting my lack of understanding. The first is about fluid loading. And typically, if we give a couple of liters of saline, which is incredible to do, especially during stage 2 sleep, you know, even after 30, 40 minutes, probably a third of it stays in the vascular and the rest, you know, will go into the interstitial space. Does it matter where the fluid goes?
That's a great question. And then, yes, it absolutely matters where the fluid is going. And then whether it is in the vascular system or it's in the, or even how much of that being controlled by the renal system. Like one of the observations that we had was that our younger population were urinating more even during that period to basically excrete the extra fluid. So there's so many mechanisms that are in place to control, so the renal function has a better response to manage that fluid. At that study, we were not able to address where the fluid is going. We were preventing the fluid to get into the legs during the sleep. So we had the subjects to wear compression stockings so the fluid doesn't get into the leg and it stays in the upper body. But how much of that gets into the abdomen and splanchnic tissue or body compared to the rest of the thorax, we don't know. And even within that, we don't know if it's how much of that intravascular or interstitial. And those are all the good questions to answer. The new technologies that we are working and developing for fluid monitoring is going to monitor fluid in a range of, or bioelectrical impedance in a range of frequencies that can then differentiate between intracellular, extracellular, that would be more fluid that could be more associated with intravascular.
It's fascinating. Instead of my limited understanding of seeing some blood gases following a lead to a saline is people get some mild metabolic acidosis. So there's probably the direct effects of fluid and the indirect effects of, acidotic changes as well.
That's an excellent point. Thank you. That is something that we could look into that. And that's the other part that we didn't look at, even like how different types of solutions may affect the fluid. And then where the fluid is going. Yeah,
it's great. And just a quick final question. I mean, if you manipulate fluid with calf compression or low body positive, negative pressure, then of course it's affecting sympathetics by a blood pressure control mechanism. So is it the fluid, or is it some direct and indirect effects of sympathetic activity?
That's an excellent question. And we looked about that. I mean, we thought about that a lot, because that was one of the reasons that we looked at the heart rate variability in the population that developed sleep apnea with the saline infusion compared to the other one. And we showed that they had a reduced vagal tone or parasympathetic response to the extra fluid that will affect their fluid retention, or like the effects of fluid on the airway. So that is potentially one of the mechanisms, but we haven't done more in depth on that. That's a very good question to look into, that how much of that is driven by just the amount of the fluid or the volume of the fluid that is coming, or how much of that is driven by the changes in the sympathetic and parasympathetic activity just because of the fluid.
Yeah, great. Thanks so much. The final thought, not really question, is I wonder, what the best or the optimum hydration state should be. If we want people to be a little bit, hyperhydrated.
I think, and that's a good question, because we don't want to end up telling people don't drink. It's more to make sure that you don't get, or the people don't get fluid accumulated in the legs or other parts of the body as an interstitial space that comes out of the circulation system. So it's like as if the legs now become a reservoir for extra fluid that should have been excreted from the system.
That's great.
I don't think that, I don't think that from my research, we can go beyond that. And then any question about what would be the optimum level of the hydration, we never had the capacity to answer that question.
Great. Thank you. Fantastic.
All right. Well, I'm sure there are other PIs who have questions, but in an effort to give our trainees chance to speak with Azadeh, we're going to we'll say thank you one more time for the excellent talk. Very, as Neil and Phil said, just super impressive, very broad research that you showed. But we'll ask all the PIs to sign off, and we'll leave the trainees to have a bit of time with you.
Thank you very much for the excellent questions and thoughts.